people, maybe we should get started. And I'd like to welcome everybody to this week's Grand Rounds and introduce you all to Dr. Alex Kaplan, who is our faculty presenter today. Dr. Kaplan, first of all, is a good friend of mine. And before I tell you a little bit about him, I just want to tell you that he's the nicest guy in ophthalmology, and that more so than his accomplishments, I think that's the most important thing. He just is such a kind, gentle individual, always smiling and always helpful. So Alex, thank you for many, many years of friendship. For those who don't know Alex Kaplan is a very accomplished ophthalmologist who practices out of the Toronto Western Hospital as well as the Kensington Eye Institute, and practices both comprehensive ophthalmology as well as medical retina and uveitis. After completing his residency at the University of Toronto, he went on to do a medical retina and uveitis fellowship at the NIH before he was recruited back to our department. So Alex, thank you for presenting this morning, and I'd like to hand it over to you.
Thank you so much, Amandeep. It's a very kind introduction. So we have two all-star presenters. We have Prem Nachani, who is our PGY2 resident in our departments. We have Ryan Mason, who's a PGY3 in our departments. And we basically just have a few cases to present, interesting cases. We'll call them mystery cases. So we'll try to make it interactive. We have a few questions that we'll take as polls at the audience. And if anybody has any questions, please feel free to write them in the chat box, and we'll try to address any kind of take-home learning points. I think the best cases to use are for the residents are cases that they see that come in, while on call or while in clinics. So some of these cases actually Prem and Ryan have seen themselves. So I'll hand it over to Prem to kick us off.
Thanks, Dr. Kaplan. I'm just going to get my slides up here. Perfect. Okay. Are my slides visible?
Yes.
Okay. Thank you. So I'm Prem, second-year resident. Just want to start off by thanking everyone involved with these cases and for the department for the opportunity to present these cases today. So the first case, mystery case number 1, is a recurrent unilateral uveitis in a 38-year-old male. This 38-year-old male was referred to us for iritis in the right eye that was not responding to 2 days of topical therapy. The patient reported decreased visual acuity, pain, redness, photophobia for 6 days, and 1 day of floaters in that eye. And this prompted him to visit a community emergency department where he was seen by an ophthalmologist, treated for iritis with Maxidex drops every hour and ointment at night for 2 days. His past ocular history included some sort of similar symptoms 15 years prior, and he was treated with an unknown regimen of topical agents. His social history includes being an immigrant from Colombia, an ex-smoker, no drug use, and no history of STIs. And a uveitis review of systems was also unremarkable. In terms of his visual acuity, in the affected eye, it was 20/40-2, normal in the left. Pupils are normal, and pressures were also within normal limits. In terms of slit lamp findings, in the affected eye, there was trace hyperemia. The cornea, there were some SBK. Notably, there were some fine and mud and fat keratotic precipitates. The anterior chamber was deep. There were about 15 to 20 cells per high power field and flare. No iris findings, and the lens was clear. Is someone in the audience able to volunteer to describe these images?
Alex, why don't you pick a year? Oh, you're muted, Alex.
Okay.
Sorry. Why don't we pick a PG? Why don't we start with a PGY2? We'll save some of the harder the cases for PGY5 like Michael Meehan.
So maybe we can have one of the PGY2s in the room just quickly review these images for us.
There's currently no PGY2 in the room.
Okay, let's go to PGY3.
There are 3.
You can just talk. Hello, I don't know if you can hear me. So can you hear me now? Is that good?
Yes, we can hear you.
Awesome, sounds good. So it looks like we have a color fundus photo of the right eye. We'll start at that image first. The posterior pole looks hazy. It looks like a component of vitreous haze and possibly some vitreous cells. There's also most strikingly a focal white lesion superior to the right optic nerve with pigmented nature surrounding this white scar. And mild, it looks like possibly mild optic nerve edema. It's kind of hard to see through the vitritis. And the image on the right-hand side of the screen is a fundus autofluorescence image of the right eye. And it demonstrates corresponding to that white lesion, a hypo-autofluorescent lesion, most likely due to rheumatoid atrophy and that's probably what I frequently see in those photos.
That's perfect. That's great.
So thanks, Austin, for answering that. That you got it bang on. So exactly, there's a 3+ vitritis in this eye, a white focal retinitis, just inferior to that, and more posteriorly is that pigmented scar with some mild optic nerve head edema that might not be fully appreciated on the image, and then a FAF of the same eye with a hypoautofluorescent lesion, like you said, showing some retinal scarring and RP atrophy due to what is presumed some sort of ocular infection that the patient may have had 15 years ago as per history. So this is an audience participation question. I don't know if the poll shows up for you.
I'll launch the poll right now.
Perfect. Oops, sorry. I just hopefully no one saw those answers, but it might not even be the correct answer anyways. So the question essentially is, which of the following would be the next best step to confirm the diagnosis and start treatment? The options are toxo IgM titer, toxo IgG titer, HIV, syphilis testing, HLA-B27, a chest x-ray, and number 7 is you're so confident in your diagnosis, you wouldn't order any additional testing to confirm your suspicion, and you think it's a clinical diagnosis, you'd start treatment right away. So we'll just give this a couple more seconds and then we'll move on.
Okay, we'll end the poll there.
Perfect. Okay, I don't see the
results.
Great, perfect. Okay, I think this is exactly what Dr. Kaplan and I were expecting when we created this poll question. So explain we think each response is right or wrong. So essentially, there are multiple tests that you need to consider, and apart from an typical uveitis workup, we ordered a toxo titer, and IgG was detected. However, the lab result also included a caveat stating that the result must be interpreted in the context of clinical presentation. And the reason for this is because 22.5% of the US population is IgG positive. So IgG is not a specific test. It might be sensitive to help rule out the disease. Just because you have it doesn't mean that you have ocular toxoplasmosis. And ordering the other tests is definitely important as well, because you want to make sure you're ruling other things out. So in terms of a differential diagnosis, given significant vitritis with a poor view of the posterior segment, in many similar cases, it's prudent to rule out other ocular infections, infectious and autoimmune etiologies, such as acute retinal necrosis and CMV, for example. On the other hand, there are key telltale findings in this case that essentially make a slam dunk clinical diagnosis. With the appropriate history, recurrent toxoplasmosis with a unilateral active lesion, white focal retinitis lesion, commonly known as headlight in the fog, that is associated with one or more adjacent chorioretinal scars, is virtually pathognomonic for ocular toxo. So in summary, this was a 38-year-old male with a pigmented scar, adjacent area of retinitis, positive toxo IgG serology, and a presumed diagnosis of toxoretinochoroiditis with a previous episode. And of note, ocular toxoplasmosis is the most common infective cause of posterior uveitis in immunocompetent patients. So a strong understanding of management is crucial, and we'll get into that now. So there's one more audience participation question here. And the question is, what is your preferred antiparasitic to treat toxoplasmosis retinochoroiditis? And we'll give this a couple seconds again. The options are triple therapy with a prednisone taper, Septra with a prednisone taper, oral clinda with a pred taper, intravitreal clindamycin with a pred taper, spiramycin with a pred taper, and azithromycin with a pred taper. We'll just give this a couple more seconds. Great, perfect. Okay, alrighty, and great, perfect. I think those are often the first option, the triple therapy with pred and Septra with pred are the two most common things I've seen, although I haven't seen as much as Dr. Kaplan yet for sure. And there's no one correct answer. However, when treatment is started, most may start antiparasitics 48 hours prior to the initiation of a pred taper, which should be stopped 10 to 14 days prior to discontinuing antibiotic therapy. And to get into indications for treatment, there are multiple different indications, including a lesion that threatens the macula and optic nerve head, just to reduce different complications with regards to vision. If you have a significantly reduced visual acuity as well, that's a reason to start treatment. For immunocompromised patients who may not be able to mount an immune response, that's another indication. For patients who are pregnant, if it's their first active toxo infection, there's a risk of vertical transmission to the fetus. And of course, if you're monocular, you want to, or if the patient's monocular, you'd want to treat the patient to prevent them from losing that eye. Sorry, and just going to the different types of treatment here. There are multiple different treatment options, including that classic triple therapy with prednisone and other systemic options, local intravitreal options, and topical treatments, which we showed in the poll earlier. In terms of prevention, the AAO found level 2 evidence suggesting that long-term prophylactic treatment may reduce recurrences in chronic relapsing ocular toxoplasmosis. Other studies have shown an absolute risk reduction with Septra DS every 2 days of about 13 to 17%. However, we need to remember that there are adverse effects. For example, with Septra, common side effects include poor appetite, other GI upset, dizziness, rash, photosensitivity. So patients who are being treated with prophylactic therapy require monitoring and sometimes timely discontinuation of the prophylactic regimen. And this is a case where you may want to treat prophylactically. For example, we can see multiple toxo scars with the most recent toxo lesion getting closer and closer to the macula and to the optic nerve. And this is a different case that Dr. Kaplan had. In terms of intravitreal clindamycin, which you probably have heard about, the indications for this are to reduce the number of the types of oral medication side effects. For example, with pyrimethamine, there are hematologic complications such as thrombocytopenia, leukopenia, despite folinic acid supplementation. With oral clindamycin, for example, you have an increased risk of C. diff and very bothersome diarrhea. Another reason to treat might be disease progression despite oral agents, and again, to limit foveal or optic nerve head involvement. In terms of benefits, intravitreal clinda has excellent bioavailability. There are reduced risks of systemic side effects, lower toxicity, and the outcomes are similar to triple therapy. In patients with elevated IgM, systemic instead of intravitreal therapy may be indicated in some cases. However, it's not clear. Some studies in 2013 and 2011 have showed that intravitreal clinda actually has increased visual acuity versus triple therapy. In 2007, multiple other authors have also documented increased visual acuity with clinda. And just a fun fact, in 2015, there was a pharmaceutical executive who raised the price of Daraprim, which is the brand name of pyrimethamine, from $13.50 to around $800, so about 5,000%. He eventually resigned, but the price of a 30-day course of 25 milligram Daraprim costs about $20,000 US. So it's quite burdensome to a patient. And the downsides of intravitreal clinda, technically with an intravitreal injection, there's possibly increased risk of infection, but because you're giving an antibiotic, that risk is probably not the same as otherwise. And there's also IVI-related anxiety. And we also need expertise. So who's actually going to do the injections as opposed to the ease with prescribing oral pills. So that is our case on Toxo. Unfortunately, the patient wasn't able to follow up appropriately, so we don't have a proper outcome data yet, but hopefully we'll have that soon.
That's great.
So moving
just before you move on to case number 2, I just want to give a 2-second Toxo take-home pearl update. So as Prem said, whenever you see a pigmented scar adjacent area of retinitis, the first thing that comes to mind should be Toxo. Toxo is a clinical diagnosis. Yes, you can order a uveitis workup to rule out mimickers. In this case, it pretty much is a slam dunk presentation. You see the retinitis, you see a very clear scar, but often it doesn't look like this. Often there's so much vitritis, you see some white retinitis or something white through dense vitritis, and it can be really hard to tell if there's something else going on. So if that's the case, before starting someone on a quad therapy and oral prednisone, which could potentially make something worse if it's not Toxo. Usually I start with an AC tap to rule out viral, because whenever you see white retinitis, you always want to rule out other infectious causes, and just being cautious to start prednisone sometimes until some of your uveitis workup comes back. So if it's a classic presentation like this one, Toxo really is a clinical diagnosis. But if you're unsure and there's a dense vitritis, always be safe. Get your full uveitis workup to rule out other mimickers. Get an AC tap to rule out viral, just to make sure that you have the correct diagnosis.
And Alex, is your initial therapy triple therapy, or do you go with Septra, or what would you choose here?
Yeah, so all of those, it can be confusing, because when you read, all of those treatments work very well with Toxo, because of what Prem mentioned. The classic triple therapy that you see in all the textbooks, practically no one uses, because from a feasibility perspective, it's just so expensive, like thousands and thousands of dollars to complete a treatment. If you're at a place like NEI where all the drugs are covered by the US government, it's something that we would use. But outside of any kind of federal funding institution, no one uses it. So classically, people would use Septra or Bactrim as a good alternative. If someone is sulfa allergic, you can use azithromycin as an alternative. And then some people are just kind of antibiotic intolerant, and there's more and more reports of using intravitreal clindamycin as an alternative. It costs about $60. You can get it made at most compounding pharmacies, and they usually dose it at once a week. After 2 or 3 injections, they usually have enough to kind of treat the infection. Also keep in mind, Toxo is usually a self-limiting condition. So, these are usually patients, by the time they end up seeing one of us, they usually meet criteria for treatment. But definitely if someone's immunocompromised, or there's other concern that the Toxo infection may not resolve on its own, definitely those are all cases that you would want to treat. So I use Septra double strength as my first line. Azithromycin, some people use just to remove the potential for a sulfa allergy altogether, and they just have that standard azithromycin dose that they use. I find azithromycin is not as effective personally as Septra, so that's why it usually is my first line agent to go for something like that.
Alex, could you comment on the prophylactic use of anti-toxo medications preoperatively, specifically whether it's an intraocular procedure like a cataract, or a pterygium if it's not an intraocular or lid procedure, and also for how long, if you are instituting prophylactic treatment, how long you continue it for after the operation?
Great question. Prem, can you just go back to that picture I sent you with the recurrent Toxo? So basically the dose that I put people on is Septra double strength Monday, Wednesday, Friday. So I usually just put them on that 3 times a week, and that's usually enough to prevent recurrences. If someone is going for cataract surgery, retinal surgery, any kind of ocular surgery, just the stress of the surgery can precipitate a toxo reactivation, because the toxo infection it's in a cystic form, so reactivation is always possible. I usually don't put someone on prophylaxis if I see a toxo scar and they've had one episode and they haven't had a history of multiple recurrences. It's something that I would consent them for at the time of surgery, just so that they're aware of that. But you know, the risk of putting them on antibiotics for such a low risk of recurrence, I think, is low. For a patient that kind of looks like the case below, where there's been multiple recurrences, it's right at the macula, you know, risk of future recurrence would have a very visually significant implication, then this is someone that I would definitely suggest keeping on prophylaxis. You know, the toxo that comes from Brazil, actually a lot of the experts in toxo come from South America and Brazil, because they just see so much of it. They advocate heavily for prophylaxis, and this was a patient actually that was from Brazil, and I keep them on someone like this. You may potentially just keep them on it forever if they're able to tolerate it, just because a reactivation would have a really visually significant implication. So to summarize, I would say that I don't put people on prophylaxis for pre-surgery purposes routinely, unless it looks something like this.
Thank you.
Alex, there's a question for you in the chat here. What's your dose of prednisone?
Okay, so you usually start your antibiotics for 48 hours. So if I had the case, you know, that Prem presented, I would put them on Septra double strength twice a day. And then say 48 hours after you start the Septra, I want you to start oral prednisone. And I usually do prednisone 60 milligrams once daily, unless they are less than 60 kilos. So I wouldn't go above 1 milligram per kilogram. I would do usually what's less, and 60 milligrams is usually fine. And then I usually taper by 10 milligrams every week. So they're on a 6-week course of Septra. And by the end of the 6 weeks, they're finished their prednisone and their Septra. You just want to make sure that they're not on prednisone, that when they're on prednisone, they're always on an antiparasitic, like they're always on Septra at the same time to cover them.
Thank you. There's a follow-up question as well. What's the downside of longer-term prophylactic Septra?
Mainly C. diff. The risk of C. diff is low. Clindamycin has a very high risk of C. diff. That's why it's not my antibiotic of choice in the beginning. If you're giving it intravitreal, it's obviously fine. Sometimes people add Clinda in addition, like you could do triple therapy plus Clinda for like a really resistant toxo. So it works well, clindamycin, but I usually prefer Septra because of the lower rate of C. diff. That's a great question.
Thank you. Oh, sorry, one more for you, Alex, or Prem. If you've previously treated toxo with Septra, in the past, would you change therapy if there's a recurrence?
So I personally wouldn't. Keep in mind, you know, these are not clearing the infection. It's really just trying to have the active infection go back into its cystic form, right? So if it worked in the past, it likely will continue to work again. And these infections are usually self-limiting. You're just trying to speed up the resolution so that you don't end up getting a massive scar. So it's really just it's damage control. So I think we should continue going because Prem still has one more case and Ryan still needs to present. But these are great questions.
Okay, thanks everyone for those questions. So the second case is a rare unilateral uveitis in a 61-year-old male who presented with blurry vision for a month. He's a big historian, and his only past ocular history includes cataract surgery in the affected eye. In terms of his visual acuity, 20/40 in the right, 2200 in the left, uncorrected, pupils were normal and pressures were normal. In terms of slit lamp exam, just focusing on the affected eye, so the left eye, conch sclera were normal, cornea was clear, the AC was deep, had 0.5 cells, and the iris was normal, and again, it was PCIOL. Is someone in the audience able to volunteer to describe these images, specifically just the left eye, very briefly?
Maybe just in the interest of time, we'll get you to describe it. Yeah.
Yeah, of course. So essentially focusing to the image on your right, there of the colored fundus photograph, we see a yellow placoid lesion along with a disrupted ellipsoid zone and nodular RPE elevation on OCT. A few slides later, you'll see those labeled. So again, just in the interest of time, maybe we won't go through this poll, but essentially there are multiple things.
I'll put the poll. I'll put the poll up. Yeah.
Okay. Alrighty. So the poll question is: what is at the top of your differential, just based on those findings so far? The options are birdshot chorioretinopathy, tuberculosis, geographic atrophy, syphilis, myopic degeneration, and multiple evanescent white dot syndrome, or MUDS. We'll just give this a couple seconds.
Isn't it always syphilis?
When in doubt.
Great. Okay. Thank you, everyone, for answering that. So we took a step back and just got a little bit more information from this patient. On further questioning, he smokes half a pack a day. He's an IV drug user with various different drugs, and he has multiple sexual partners. He may have had a history of a TB infection, but that's unclear. And most notably, he thought it was unrelated, but he actually had a new rash on his palms and on his chest. And essentially on the palms here, we can see a sort of circular lesions that resemble some sort of plaque-like maculopapular rash. And on the chest, we see a maculopapular rash as well. So this, just going back to the image here, we can see that yellow placoid lesion, a disrupted EZ and nodular RPE elevation on OCT. So in summary, this case involved a 61-year-old male with decreased visual acuity for a month. He had IV drug use, a new rash on his chest and hands, a mild vitritis, posterior placoid lesion, positive syphilis and HIV testing. And he was diagnosed with, like Dr. Rai said, when in doubt, syphilis, acute syphilitic posterior placoid chorioretinitis. So we have another audience participation question. Which of the following is the next best step for this patient? There are 4 options. First one is lumbar puncture and CSF analysis, penicillin intramuscular injection, doxycycline oral, and a stat referral to the ID team for management. I don't know if there's
Prem,
a
unfortunately,
poll.
I don't think we have a poll for this one, so maybe
That's
you can
okay.
keep us going. Thank
Alrighty.
you.
So essentially the point we aim to get across with this question is that the patient requires urgent treatment with penicillin. However, it should be via an intravenous route, which excludes 2 and 3. A lumbar puncture is important. I'll get to that in a second, but it may take longer to organize versus the ID team who can start treatment right away and organize that lumbar puncture. So while syphilitic uveitis typically denotes secondary syphilis, ocular involvement can occur in any stage. On the other hand, syphilitic uveitis represents a breakdown of the blood-brain barrier or blood-ocular barrier, and it should be treated as neurosyphilis. So this is aqueous crystalline penicillin G, 3 to 4 million units every 4 hours for 10 to 14 days, or you can do it IV as well, and then followed by, you can do an intramuscular injection later on. But it's also important to evaluate for tertiary or neurosyphilis, and that's where an LP comes in. The LP is to measure levels of CSF VDRL. And if the CSF is normal, you can base follow-up labs on serum VDRL at 3 months post-treatment. And treatment success is based on a 4-fold decline in titers. If the CSF is abnormal, meaning there's neurosyphilis based on the LP, you would repeat the LP every 6 months for 2 years. So we treated this patient with penicillin G IV every day for 14 days, as well as the Predfort 1% topical therapy every 2 hours, which was eventually tapered. This resulted in improvement of his hand rash as well as the rash on his chest, and the placoid lesion is not really visible anymore on that colored fundus photograph of the left eye, and we don't see ellipsoid zone disruption or nodular RPE elevation on OCT. So that's essentially that case. Just tried to keep it very brief so Ryan can present. but hopefully that summarizes the treatment for syphilis as well as how to diagnose it. And when in doubt, like Dr. Rice said, always think about syphilis.
That's great, Prem. Thank you so much. So just to summarize a few take-home learning points over here. So exactly like mentioned, always think about syphilis. In particular, syphilis can affect any part of the eye. This is a very interesting case of posterior placoid syphilis. So syphilis loves outer retina. So whenever you see a uveitis, where there are those little deposits at the level of the RPE and the outer retina is missing, those are cases where you should be thinking of syphilis in the differential diagnosis, because that's an infectious cause that is curable. There was a question about investigations. In Ontario now, when you order, it doesn't really matter what you write, as long as you write syphilis on the public health form, they have a standard way of ordering it. They used to do kind of like a non-treponemal testing first. So if you did a RPR or VDRL, then it would trigger a treponemal testing. Now in Ontario, as long as you just write syphilis, they'll first do an IgG syphilis testing, which will, if positive, will go to a VDRL confirmatory test for an active disease. And then you will get a dilution factor in terms of how positive the test was. The more dilutions that it takes, the higher, the more positive your test is. So it doesn't matter what you write, just write syphilis. And you always need to fill in both forms. Like there's the Ontario lab form, you write syphilis, and you need the Ontario microbiology form to write syphilis. You need both, otherwise it'll get rejected. Okay.
Alex and Prem, by definition, as you said, ocular syphilis refers to neurosyphilis. So why are you doing the LP? And don't you assume that this is neurosyphilis and you'll treat forward?
The great question. You'll find different ID doctors do different things. At UHN, depending on the ID doctor that is on call or that sees the patient, sometimes they will advocate for an LP, because that is the textbook thing to do, is if there's ocular syphilis that you want to rule out that it's in the CSF. Also, it gives another metric to follow to ensure that you're getting an accurate reduction in the RPR levels as treatment occurs. Typically they say it's actually 10 to 14 days of IV penicillin treatment. I always see 14 days, but I guess from the LP perspective, like you mentioned, I've seen both. I think the textbook thing is that they still want to ensure that the CSF is clear. But many ID people will just say, we'll treat it and we'll just follow the eye, assuming that everything else is okay. Okay, so if there's no more questions, I think we'll move on to Ryan's case.
Okay, great, thanks. So I'd like to thank Dr. Kaplan for allowing me to speak today, and also Dr. Tarani. During my rotation at Sick Kids, these two cases came through. So for case one, it's a 12-year-old male, we'll call him Mr. IR, that presented to the eye clinic from optometry with a referral for posterior uveitis. And this was found on routine exam, and the patient presented asymptomatically. He had not had an eye exam probably since the age of 4 or 5 years old. There was a past medical history of being COVID positive earlier in the year, but a fairly mild case. He was on no medications and had no other ocular history or significant family history. On assessment, his vision was visual acuity and color vision were preserved in both eyes. Pressures and pupils were normal. And looking at the anterior segment, there was no cell or flare or signs of either anterior segment or orbital inflammation. However, when we looked at the back of the eye, he had +1 vitreous cell in both eyes, but no snowballs or snow banking, and some pretty impressive and surprising retinal findings given his preserved acuity. You can see in both eyes, might be a bit hard to see here, but the discs are a bit hyperemic, and there was a bit of disc edema in both eyes with blurring of the nasal margins. Along the superior and inferior arcades in both eyes, there was lipid exudation. There are some retinal hemorrhages you can see here. And as we move out into the periphery, there's some regions of vessel ghosting that could be suggestive of ischemia. Looking at the OCT, the fovea was normal in both eyes, accounting for the preserved visual acuity. And you can see some hyperreflective deposits in the outer nuclear layer, more on the left than the right. While we were seeing this patient in clinic, we also had a very similar case of a 13-year-old female that presented from the optometrist with bilateral disc edema. And again, found on routine exam, she was asymptomatic, had not had an eye exam in a number of years. There was no past medical history. Of note, her body mass index was within the normal range. She was on no medications, had no ocular history, and other than a history of strabismus in her mother, there was no family history. Again, the visual acuity was normal, color vision was normal, intraocular pressures and pupils were normal, and there was no inflammation in the anterior segment. When we looked at the back of the eye, there was trace vitreous cell, otherwise a clear media. Here you can appreciate there is some disc edema and disc hyperemia with some blurring of the nasal margins in both sides. On the right eye, there is some lipid deposition, so some exudate along the inferior arcade. This is just showing the OCT confirming elevation of the RNFL thickness. Again, the fovea is spared in both cases, accounting for the good visual acuity. And as we look kind of further into the periphery, we again, very similar to the first case, can start to see some ghosting of the vessels in both eyes. And this becomes more prominent as we move further and further into the periphery. And you kind of start to get a bit of a featureless retina as you move more anteriorly in the retina. And this is the same case on both eyes. And for instance, this might be just an area of dark without pressure, but it kind of lets you see the changes in the vasculature a bit more easily. We did a very thorough review of systems. So this is a kind of a big wall of text, but needless to say, nothing came up on the history. The patients were of different ethnicity. The first patient, Mr. IR, was of Indian ethnicity, had traveled outside the country pre-pandemic. Ms. AN was born in Hong Kong and had immigrated to Canada about 6 years prior, but had no other travel. Neither had any exposure to cats or tick bites that we could elicit, and there was no environmental exposures. So this didn't really help point toward a potential etiology or help direct the investigations. So I'm not sure if there's a poll question available in the system, but the first question we can think about is, what is your next step for this patient? Would you order a comprehensive uveitis panel, so send them to the lab? Would you order a fluorescein angiography while you had them there in clinic? Would you order a stat MRI or MRA, given the disc edema and the potential neuroretinitis type presentation? Would you start them on doxycycline or start them on 1 milligram per kilogram of oral prednisone, given the vasculitic changes?
So Ryan, we don't have any more poll questions preloaded, just FYI.
Okay, so you kind of think about what you would do in this case. For us, while we had them there in clinic, we wanted to order a fluorescein angiography, given the pretty extensive vasculitic changes. We might have a bit of time. Is there a resident that would be able to describe what they see here? So here, just to remind us of what the fundus photograph looked like. And then here we have the IVFA.
Maybe we'll get a fifth-year resident to describe it.
AKA Michael, if he's there.
Okay.
Token fifth-year resident.
On the left, we see fundus photo reminding us of the left eye showing extensive exudates, perhaps a mild optic nerve head edema and retinal hemorrhages. On the right side, we have a IVFA, which looks to be in the AV phase, and along the arterioles, you can see that there are these highlighted areas that look like
aneurysms. Period.
Yeah, exactly. So I probably went a little overboard with the arrow sign here, but you can see that there's many areas where Michael was right of aneurysmal changes. And interestingly, they often occur either at the optic nerve head or at or near regions of bifurcations of the arterioles. And as we move into the periphery, we can see some pruning of the vasculature and extensive areas of capillary non-perfusion. However, there doesn't seem to be any particularly bright regions that would suggest leakage at this point. And then very similar findings in the right eye, where we have some aneurysmal changes, non-perfusion as we move into the periphery. This was our first patient, 12-year-old male. And when we look at the 13-year-old female, she does have some aneurysms here, but it's not as impressive as in the first case. But when we look in the periphery, she actually has more of the capillary non-perfusion, and the same findings in the left eye as well, with very extensive areas of non-perfusion. When we looked at the investigations, you kind of think of it in terms of infectious, inflammatory, and because of the occlusive vasculitic nature of what we were seeing, there's also a prothrombotic workup that was done. In terms of infectious, syphilis, quantiferon for TB, Bartonella, Toxo, Lyme were all negative. In one of the patients, HSV and CMV, IgG did come back positive, but it's not really in keeping with the presentation we were seeing, and ID was consulted as well. And it's likely just prior exposure to these, but really not contributing to the presentation. In terms of an inflammatory workup, one of the patients was ANA positive, one was not. So it's hard to know what to make of a positive ANA in many cases. ANCA was negative workup for lupus with dsDNA, and complement was normal. And even at recommendation of neurology, NMO spectrum was sent off, and that came back normal. For a prothrombotic workup that was done on the 13-year-old female, she did have positive anticardiolipin and lipoprotein A. So she's being followed by hematology for that. She does have a bit of an increased risk of thrombosis, but given its symmetric nature in both eyes and how extensive the occlusive vasculitis was, it doesn't really look to be a thrombotic process. There's two MRIs that were done. I won't go through these just in terms of time. In the 13-year-old male, it'll come up here, he did have an incidental finding of about a 9-centimeter arachnoid cyst that was compressing on the frontal and temporal lobe. So that was found incidentally. So he'll be referred to neurosurgery for that. But nothing on MRI came up contributing to the vasculitic changes. In the 13-year-old girl, because of the avascular peripheral retina, fever, was considered, or an occlusive retinal vasculitis. So she did have a genetic panel that was done. This is a really good resource. If you ever have genetic testing that's been done on a patient, you can put in any genes of note. She was heterozygous for 2 mutations and see what ocular systemic findings they can be associated with. The first here is associated with Stickler syndrome. The second with autosomal recessive retinal dystrophies. It's not really in keeping with the patient's phenotype. So the genetic testing for her was negative. So if we look at the patients of a kind of a unique constellation of findings with disc edema, some lipid exudation, arterial aneurysms, like Michael pointed out, often near bifurcations. There's an occlusive retinal vasculitis, and as a result of that, peripheral capillary non-perfusion. So if we compare patients IR and AN, the most likely diagnosis is that they both have IRVAN, which is a pretty rare condition. It was first coined the term by Chang in 1995, and there's major and minor criteria. The major criteria are really the presenting features. So you have an idiopathic retinal vasculitis, aneurysms, and neuroretinitis. The minor criteria are the sequelae of these. with a capillary non-perfusion that can lead to neovascularization or macular exudation. In this paper presented a case series of 10 patients. Some things to note is that patients tended to be female, about 70% tend to be female, often present in their 20s to 40s, although you can have pediatric patients like we showed here. The initial presenting visual acuity is often quite good, but it can have a wide range, anywhere from 20/20 to hand motion, and it can be degraded by macular edema, lipid exudation, or vitreous hemorrhage if the aneurysms rupture. It can be hard to have these patients follow up, especially if they present asymptomatically. And vitritis and anterior segment inflammation was a very inconsistent presenting feature. There is a proposed staging system from a paper by Samuel in 2007. So you start off with aneurysms, exudation, neuroretinitis, and retinal vasculitis. The aneurysms are often at points of bifurcation and may have a Y-shaped or a fusiform type appearance. That will lead to capillary non-perfusion. You can see it maybe as a featureless retina when you look at the slit lamp or with the indirect, and IVFA is very useful for identifying this and seeing if it changes over time. You can get neovascularization developing as a result of this. In the 13-year-old, she is starting to develop a small region of neovascularization. So she'll have follow-up with retina in probably a couple of weeks, I believe, and see if they want to initiate any treatment for this. And as a result of neovascularization posteriorly, you can get NVI and then eventually neovascular glaucoma, with obviously very poor visual prognosis in those cases. And in this paper, they also presented a chart looking at the presenting visual acuity versus the stage. So here we have the number of eyes and the stage of IRVAN. If a patient presents in stage 1, 2, or 3, so with just the capillary non-perfusion or a bit of NV in the posterior segment, often they have good visual acuity, 20/20 or 20/40. However, if they present with NVI or NVG, as you might expect, the visual acuity can be degraded on presentation. So for the last question you can kind of think of is, at this stage, if you're presented with this patient with a lot of capillary non-perfusion and retinal ischemia, would you treat the patient? So options could be, I would observe them. I would do pan-retinal photocoagulation at this point. I would start an intravitreal anti-VEGF injection, or I would start a more systemic immunosuppressive therapy. So there's no poll question to launch, but you can think about what you might do in this position, and there's really no clear correct answer. So when we look at the literature, there's a number of therapies that have been trialed in these patients for medical and surgical means. With medical management, we have good evidence from other systemic or retinal vascular conditions. If there's neovascularization, you can start anti-VEGF therapies. And people have tried corticosteroids, so both oral corticosteroids or intravitreal triamcinolone or dexamethasone implants. It does have benefit for the macular edema if it's present, but it won't make any change in the degree of capillary non-perfusion and the amount of ischemic retina that's present. Immunosuppression has been tried, anti-metabolites such as Imuran and Cellcept, or infliximab has also been used. It's shown to reduce the amount of both edema, staining of the optic nerve, so it might help with the neuroretinitis piece, but it again won't really help with the degree of peripheral non-perfusion. So people have tried corticosteroids and immunosuppression, but there's really not enough evidence to say if it's beneficial in the long term. For surgical management, PRP would be the standard to do in these patients. Some will advocate to do it at stage 2 when you identify the capillary non-perfusion. Others might wait until you actually have evidence of neovascularization. And it's really based on studies of vascular occlusive events such as the CVOS studies that this treatment modality is based on. People have done cryotherapy if there's medial opacity, so you can't do the laser photocoagulation, and vitrectomy if there's a non-clearing vitreous hemorrhage or tractional retinal detachment as a result of the NV. In some of the earlier papers, people have done focal laser to the aneurysms to try to prevent them from rupturing, causing VH or other issues. But in some of those cases, when they do the focal laser, they've resulted in branch artery and retinal vein occlusion. So that's really not advised. So there's many different options, but really other than PRP, it's a bit unclear what to do for these patients. And at least for the two we're seeing at Sick Kids right now, we've involved a number of different subspecialties and rheumatologies involved, but they're not on any systemic medications at this point, and they're being monitored with serial IVFA to see if they develop any neovascularization. So thank you.
Great job, Ryan. So two very rare cases that it's always funny when two extremely rare things come in over a very short period of time. You wonder if something's kind of in the water. But yeah, I mean, I think these are obviously, you know, this is basically the story of uveitis. There's such limited data. The cases are so rare that it's really hard to make substantial conclusions. And sometimes you just need to do what's reasonable, look at the patient in front of you and kind of, you know, think if this was your eye, what would you kind of want? I mean, I think definitely the case, these two cases, what one of the most striking things about it is the degree of capillary non-perfusion and the degree of occlusions. And that's the scariest part, I think. You can definitely see along the border, there's the area of leakage, which is almost like the brush fire of an occlusive event. And my concern over here is that those areas of occlusions will expand over time. So, I mean, definitely following these patients closely with serial IVFAs, not just to look for signs of secondary complications like neovascularization, but are the occlusions getting bigger? I mean, in my mind, that would be the main reason actually here to start corticosteroids or immunosuppression if there's evidence of progression on serial IVFAs. Definitely from a PRP perspective, you know, with occlusive vasculitis in general, you know, we tend to wait to see if until there are signs of NVE or that form. You know, NV that's associated with vasculitis tends to be a bit of a slower process than, you know, NV associated with CRVO, NVIs associated with CRVO and things like that. And then often, because the mechanism is a little bit different, because there is kind of an inflammatory component, you know, sometimes, you know, starting a patient on corticosteroids around the time of PRP can be helpful and useful. But those are, I think, are the main things is over here in this case, not just the macular edema, but in such a young patient, just, you know, being concerned about the progression of occlusion over here. And even though it's minor criteria, it does seem like there's quite a bit of occlusion here. So yeah, those I think are the main take-home points. Also, just one point to add about the doing focal laser for the aneurysms. These aneurysms tend to move around and can be migratory. So they're not the classic macro aneurysms that you would see in a hypertensive patient that you could consider doing a focal laser for. These aneurysms are a little bit different. So I would, you know, I generally would, you know, not recommend lasering them because it's kind of a different type of mechanism. Yeah, so I guess when you see an occlusive retinal vasculitis on IVFA, to look very carefully at the arteries to see if you can see any aneurysms or if there's any exudate to consider IRVAN as a case.
Well, guys, thank you, Ryan and Prem. Those are fantastic presentations. I'm just looking at the chat box. There's one more question here from Dr. Ng. Did the patients have TB testing? And Ryan's already answered saying, yes, he did. So thank you, Ryan, you're on top of it. We don't have any other further questions. I want to, again, thank Prem and Ryan for those amazing presentations. Really well done. Dr. Kaplan, thank you for facilitating this morning's session. That's it for this morning. I wish everyone a very safe Halloween weekend. If you have kids, enjoy it out there. It looks like it's going to be a fun weekend. So we'll see you guys next week. Thank you, everyone.
Thanks so much.
Excellent rounds.
Thank
Thank
you.
you all.
Rounds.
Good job.
Well done.
And the link for the evaluation is there. I'll just leave the Zoom meeting open for about a minute so everyone can access that.
Brian, Prem, that was great. Good job.
Seriously, very well done, guys.
Yeah.
Amazing.
Yeah, and bang on time.
Yeah. You know, that's the trickiest
Great,
part
thanks.
sometimes. You don't want to finish too early. You don't want to finish too late. You got to get it just right. It's Goldilocks.
Yeah, it's so true. And also, especially with questions, it's hard to predict,
Yes. Yeah.
how long we'll stay on the topic. But that was great.
All right, guys, I'm going to close the Zoom link now. So thank you again. I'll see you guys when I see you.
Yeah, see you soon.
Thank you, guys. Bye.
Thank you.
All right, take care. Bye.